that effect. And I'm joined here today by other founding members of the International Coalition of Older People with HIV, or iCOPE HIV. So Anton Vasenko and Mario Cassio are representing the Quality of Life program at the European AIDS Treatment Group, or EATG. Axel Vanderpeer is founder and president of Utopia BXL, which is based in Belgium. And we have another member, Jules Levin, who's the executive director of the National AIDS Treatment Advocacy Project in New York City, but he's unable to be with us on the call right now. A little bit about what we plan to do today. I'm going to take you through some of the preliminary results from our global stakeholder survey, and then we'll have some discussion about iCOPE HIV's priority areas and how we can translate those into action. We're really interested in hearing from you about what are the activities we can do that can really bring these priorities to life? And at the end, we'll share an invitation that we're very excited about in terms of a steering committee that we're pulling together. If you have any questions as I go through the survey results, please feel free to put them in the chat. If I don't see them while I'm speaking, we'll circle back to them at the end of the presentation. We're also a relatively small group on this call, so you can feel free also just to raise your hand or unmute yourself and ask a question if you need to. So in terms of the survey, our data was collected in February and March of this year after our inaugural iCOPE HIV meeting, which was at the end of January. We had 192 people respond, and we included 177 of those responses in our analysis. The reason for removing those 15 that we took out were because though people indicated a little bit about who they were, where they lived and worked, and maybe their role, they didn't actually answer any of the other questions in the survey. So we filtered those out. So in terms of representation by region, we did have responses from all areas of the globe, though some areas much more strongly than others. So we had responses from Eastern and Southern Africa, 25, West and Central Africa, 18, Eastern Europe and Central Asia and Latin America and the Caribbean, as well as the Middle East and North Africa were our smallest groups. You can see Asia and Pacific region is divided into both the low and middle income settings and the high income settings. And then we had our strongest response from Western and Central Europe and North America, which probably represents some of our contacts as the founding members. And we're going to definitely be endeavoring to raise our engagement in some of the other global areas. Now, I organized the data that you're going to see in the analysis by region originally instead of by individual country. And so there are a few examples where there are misclassifications of countries based on whether they're high or low and middle income. So one response each from Singapore, Puerto Rico, and Chile were included in the low and middle income group, but should have been in the high income settings. And one response from Turkey was lumped in with the Western and Central European countries as high income, but should have been classified in the other group. So for the most part, the data is represented as low and middle income settings, which in the graphs will be shown in red, and high income settings, and the graphs will show in yellow. So one of the first questions that we asked was just who was participating in the survey. So you can see a strong showing by people living with HIV, some of whom identified as older people living with HIV, and frontline service providers in community-based organizations. That's very important to us here at iCOPE because we really see this as a grassroots response. So getting that input from community is really important, as well as some responses from researchers, educators, healthcare providers, and a few others. So one of the first things that we wanted to explore was whether the unmet needs of older people living with HIV are being discussed where respondents live. So about 47% said that HIV or the needs of older people living with HIV were being discussed by aging and older people living with HIV themselves. And 51% said they never, rarely, or occasionally heard this being discussed among community members. When we look at discussion among healthcare providers and those who formulate clinical recommendations for care, about 37% of our respondents indicated that they thought that healthcare providers were talking a moderate amount or a great deal about the issues facing older adults, compared with 58% who felt that that was never, rarely, or occasionally happening. And then the poorest perception was about whether these needs are being discussed among policymakers. Only 17% felt like policymakers were discussing these unmet needs a moderate amount or a great deal, which is of course troubling to us and one of the key reasons that iCOPE has come into being. So if we look at how this breaks down by setting, when we look at high income settings versus low and middle income settings, we do see that about 58% of aging and older adults in high income countries or 58% of respondents indicated that aging and older adults in high income settings were talking about their unmet needs. So that's, a fair percentage compared to only 23% in low and middle income settings. And this, of course, makes sense as the population of people living with HIV is older in some of these high income settings. So their aging related needs may be more pressing and at the forefront of the minds of people who are older already. If we look at the regional analysis of discussion among healthcare providers, you can see kind of that same pattern where the unmet needs of older people are being discussed by healthcare providers and those who write clinical care guidelines more in high income settings than in low and middle income settings, but still, even in those high income settings, less than 50% are talking about it to any great degree, which is still not ideal. And then when we look at the decision and policymakers, unfortunately, the overarching observation is that the perception among respondents is that there's very little discussion happening about these needs across the board in all jurisdictions. And this is really problematic because it indicates that there's very poor preparedness to implement some of the upstream approaches that can mitigate the factors that contribute to those unmet needs. So we see that as a problem, and we're going to talk a little bit more later in today's meeting about some approaches to potentially changing policy.
Kate, it's Tristan. Thank you very much for this. Just sorry if I missed it. I saw the breakdown by region, but what are the total numbers in the high income and in the lower middle income groups?
Oh, sorry, I should have indicated that. I believe, if I remember correctly, there were 100 and let me go back. Hold on. I can
just
tell you
how
by
much,
looking.
Yeah.
So 115 versus 62 approximately.
Okay.
Yeah.
Okay. Great, thank you.
You're welcome. Sorry, I should have said that. Okay, so, oh, sorry, go ahead. Yes.
Sorry, I one of the things on the lower income versus higher income countries, and is HIV being discussed with governments, that
Yeah.
sort of thing? That I can't remember what the question was, but the thing that immediately bounced in my mind is that it is that one of the reasons that probably one of the biggest reasons is probably discrimination and stigma. If you take the lower income countries, they're scared to bring it out. So
Yeah, that very well may be. And in situations where there's a scarcity of resources as well, it might
exactly.
seem sometimes a little bit more futile to advocate for policy change for one issue versus others. But without getting this on the radar of those policymakers, we won't see any meaningful changes. So we
That's right.
still
Yes.
want to flag it for sure.
Yes.
Thanks, John. Okay, so the next question was to ask whether the health and psychosocial needs of older people living with HIV are being met where respondents live. And only 17% of all of the respondents agreed that the health and psychosocial needs of older people living with HIV are being met where they live, which is really not great. Over 50% of respondents actually disagreed with this statement. So we see that as a problem. When we look at how that breaks down across the different income settings, the proportion of respondents who disagree that the needs of older people with HIV are being met is 50% or more, regardless of the setting. So this is really a shared view that these needs are under addressed. The proportion who agree that the needs of older people are being met in their region is below 20%, again, regardless of the setting and the region's resources. So this is where we actually see quite a bit of agreement in the data. We also explored with respondents about whether where they live, people living with HIV are aware of some of the aging-related health complications that they might be more prone to experience. And here we can see that almost 3/4 of respondents are kind of in the middle of things. They indicate a slight to moderate awareness is shared among people living with HIV in their region. But that indicates that there's significant room for education about some of these risks to enable people to make more informed health decisions as they grow older. And when we look at the breakdown across settings, you can see that there's a perception of greater awareness of these risks among people in high income countries as compared to low and middle income countries. That said, still only 44% of the respondents from high income settings indicate either a moderate or extreme level of awareness among their community members. So still lots of room for that education to be useful. In low and middle income countries, we see that respondents' perception is that 60% of people living with HIV are either not aware whatsoever or only slightly aware of these risks. So we also asked an open-ended question to find out what are some of the most significant needs facing older people living with HIV in each respondent's region. And the data that was shared here was incredibly rich. We tried to code it into or organize it by codes into themes, and those are shown here in the word cloud. And for those who aren't familiar with this type of graphic, basically the bigger the word is, the more responses it represents. So the bigger words represent the major themes. And as you can see, comorbidities, isolation and stigma, and some of the social determinants of health, like housing and finances, were really commonly cited. So I'm going to tell you a little bit more about these themes just now. So we organized the themes according to iCOPE HIV's priority areas, which are care, quality of life, and empowerment. So in the domain of care, there were comments about a lack of specific services, for example, tailored care for older people living with HIV, or a lack of appropriate models of service delivery. So for example, culturally competent care for people as they're aging, and maybe looking for ethnoculturally specific responses, women-specific responses, and wanting some specificity in that. But respondents also describe barriers to accessing existing services that people who aren't living with HIV seem to have more luck accessing. There were concerns definitely about quality of care, questions about whether carers were knowledgeable about HIV and aging, and whether care was comprehensive, and definitely feelings that it was not being integrated across providers. This came up time and time again. And finally, a lot of unmet needs for care related to comorbidities, so including prevention, screening, and management of those conditions. And you can see in these bubbles just a few sample comments from the survey respondents. And when we look at the needs that were expressed that pertain to quality of life, people indicated that folks living with HIV and aging with HIV in their regions were experiencing disability in some cases and feeling poorly, largely due to mental health issues, pain, challenges with sleep, and other kind of non-comorbidities, but symptoms of various problems that might be underlying. Respondents also really commonly mentioned worries about adequate resources for people to age well with HIV. And those resources were money, insurance, food, affordable health services, and housing. And something that I found quite interesting was that these unmet basic needs were seen across both high and low and middle income settings, indicating that access to resources at a country level definitely does not necessarily trickle down to the individual. Other key themes were affecting quality of life, were social isolation, loneliness, and stigma, which came up quite a bit. Yes, John.
Sorry.
No, that's fine.
Because we have high income countries, and even though I don't have the typical Australian accent, for example, Australia, and I know this can be for other countries, so I'm just using here, is that yes, we do have HIV organizations, well, it's basically clustered into our capital, the cities, as you would know, Sydney, Melbourne, Brisbane.
Yeah.
As soon as you leave the metropolitan area, it's not there. So even like the HIV International Day for Long-Term Survivors Day coming up on June 5th, there's nothing out in the outside of the capital cities, and there's no transportation to go in and partake. And that's the same with medical health. So I know that's other countries as well. I just wanted to add that in. It may look like a country is doing well, but it's only in the capital big cities.
Yeah, that's something I can absolutely relate to. In Canada, we
I
don't
figured
have
that's so
we
too.
don't have one healthcare system. We have 14. So each province and territory has its own ways of handling things. And you're absolutely right. In our more rural areas, Transportation is a huge issue, distance from other people living with HIV, but also from services is something that people are really worried about, especially as they get older and might need more social support, practical support. A lot of folks are expressing that they don't feel like that's there very strongly.
I promise not to go on too much
No,
about
it's fine.
If I can add,
the problem in Australia is that the service providers are in the capital cities. No matter whether it's 8 hours or an hour or one way, there's clusters of HIV. There's HIV long-term survivors, elders, and they live outside. And we don't know, we don't even have subgroups to even, because we don't even know each other.
Right.
And so the isolation, someone could just live a kilometer away from me or 10, and we can't get together, while in Melbourne, they have monthly events and we don't.
There's nothing to facilitate that connection with each other.
Well, they don't try. That's the thing, they don't try. And I brought this up and they don't try, so.
That's really important. Thanks for sharing that, John.
Yeah,
Mario,
sorry.
did you want to add something too?
I just wanted to add something. Okay, and let's say in countries in the European part of the world, I mean, where distances are maybe a bit closer than compared to, let's say, Canada or the USA or Australia. So we have similar problems, I mean, between rural areas and the bigger cities, but also due to the fact, which is also not only the distance, the difficulties in traveling and so on, but stigma, for example. Okay, so living in small centers, for example, I think this is worldwide. It's something, and this is particularly becoming a problem for older people. I mean, some of the services I do as a local level here, for example, I see that all the people outside of the major city are all in ages over 60, 65. So when you're younger, maybe you're willing to travel or do things, but as soon as you get older, even those minimum services that are offered, you don't access them any longer, for example. So it is a big problem. So people
and we move out of the cities often as we get older, and on top of it, we get unwell and frail, and then there's also environmental problems of getting to the cities.
Absolutely. Absolutely. Okay, we will come back to some potential solutions around that as we move forward through the webinar. But the final sort of area or domain that we want to focus on at iCOPE is empowerment, and education and information, and kind of lack of answers to a lot of outstanding questions came up often in the survey. But people also talked about the feeling of being invisible as older people, and perceptions that systems and communities were ageist and not really interested in meeting their needs as much as other groups. So something to pay attention to as well. So when we asked respondents to indicate which of our 3 priorities kind of should be the highest priority, the respondents kind of were equally split between the first one, which is focused on increasing the capacity of decision makers to implement comprehensive models of care, and the third objective, which was around increasing knowledge of aging-related health conditions and their management among older people living with HIV. Now, we have the feeling, though, that this question got a bit skewed by our own error, in that we stated the second objective as more of an activity instead of indicating that the second objective was really meant to prioritize quality of life, which, based on the feedback from the open-ended responses, we did see that that was important to people as well. So this may be taken with a bit of a grain of salt. we saw that the objectives were prioritized in much the same way across both low and middle and high resource settings. So we didn't see much difference there. So when we ask people about their needs for information or learning, and we ask them to rate a large variety of topics as either high, moderate, or low priority, you can see the data here on the proportion of respondents that rated a topic as high priority. Some of the most strongly rated topics were mental and emotional well-being, aging-related comorbidities, loneliness and social isolation, advocacy and policy change, and cognitive changes and management strategies. But not too far behind were things like long-term care and retirement living, and kind of questions about who's going to look after me as I get older, in-home care. And, you know, overall, there was prioritization of almost every issue to some degree or another. We just wanted to get a bit of a sense of where to start, because obviously we can't necessarily tackle everything all at once. When we asked about preferred methods of interacting with us at iCOPE, there was a strong preference for these kind of live interactive webinars or opportunities to exchange information, as well as email. Lesser preferences for website and communication on social media, but Facebook was the preferred avenue if we went that way. And preferred methods of learning, again, were these kind of live opportunities to get together. I think there's a lot of benefit in having the opportunity to talk about some of the results, reports on best and promising practices, so we can learn from each other around the world about what's working well and maybe what isn't working so well. And then, you know, some other options around recorded webinars, research summaries, informal exchanges on social media, etc. Are options too. So that's the results of the survey. Before we move into kind of our in-depth discussion, are there any final reflections on the survey? Tristan, I saw you said something in the chat about wondering if something was the same for older adults not living with HIV, but by the time I saw it, I didn't know what it was related to.
Yeah, no, it was just about the obviously a lot of these issues relate to people as they age generally. So I think there's something very important about the fact that, of course, we want to support those general needs for everyone living with HIV, but also it's going to be very important to tease out those that are particularly HIV specific, in terms of where we have expertise, particularly thinking about coordinating those, and supporting the issues that relate to HIV in particular, whilst being mindful of the general aspects of aging. And I guess for that, you need some idea in country of what applies to people who are not living with HIV in addition to those who are.
Absolutely. Thanks for that, Tristan. Okay, so I'm going to turn over the conversation first to Anton, who's going to talk about our first priority and translating that into action. We're going to hear about all three priorities from Anton, Mario, and Axel, and then we'll open up the discussion for comments on all of the activities we could undertake together. So feel free to put things in the chat box while they're sharing kind of our ideas about some potential avenues, so you don't forget, or even raise your hand so that we come to you at the end of the discussion. But what we found in our first webinar is we opened up discussion after each one, and we ended up talking about the ones that were yet to come. So I think we'll just cover them all, and then we can open up room for discussion. So Anton, I'll turn it over to you.
Yeah, thanks, Kate. Thanks a lot. It was really interesting presentation and data, and I think it's cool that today we have like a more chamber-like atmosphere, given the number of participants, and I think I expect really interesting discussions in the next three around next three priorities. So I'm Anton. I'm from Ukraine originally, and I think it's always good to, you know, to any discussions, or especially when we're talking how to transfer, or I don't know, to turn theory or tokenistic things to real action. It's always good to bring some personal perspective and trying to look through the lens of, I don't know, certain conditional person of living with HIV and aging with HIV. Of course, this particular part is based on my personal story, but it's quite typical for the region and for the country from where I'm from. So as I said, I'm from Ukraine. From Kiev, and it's Eastern Europe, Central Asia. It's still the region where HIV epidemics is still growing. Mostly it's low and middle income countries in that part of the world. And I live with HIV so far 20 years. So now I'm 43 and I live with HIV 20 years. But what more important, I'm a person who used drugs more than 20 years. And actually that's quite a typical story for the generation of 90s. I was born in 80 and 90s, as you remember, Soviet Union occupation ended, fall off of Iron Curtain, 15, let's say, it's not new, but it's finally independent countries, and absolutely new reality for I don't know, children, family, youth, etc. So yeah, so the story of using some substances at that time was quite typical. And of course, in the situation of complete absence of programs like harm reduction, needle in syringe, etc., it was really not a surprise for me to find out in 2003 that I'm HIV positive and hepatitis C positive as a person who injects drugs. Yeah, so as I said, as for now, I'm living with HIV 20 years, but and of course, in my 43, I have a so huge list of different health issues based on either my HIV related or substance use related, that sometimes people at, I don't know, at 70 or 80 much healthier than I am, you know, things like polyneuropathy or other cardiovascular things, or problems with my veins, etc., etc. So, but again, it's just a personal context of the person facing with HIV and living with HIV so many years, but also so from certain time I started to work in the area, and of course being an activist and representative of communities of people living with HIV or people who use drugs. Of course, we faced with the reality of when we want to raise our voices and change something and bring some needs of the communities, we in our countries always first is what about decision makers, how you can convince decision makers to make some changes, or to support you with certain resources, or the program with certain resources, etc., etc. So that is why it's all very related to the discussions about increasing the capacity among decision makers. There are a few things from yesterday's discussion. First of all, I think it needs clarification who we mean under decision makers. I think so. So as an example, it's any person whose decision, so it can be even, you know, chief doctor of certain healthcare facility, or member of parliament, or minister of health, but every person, policymaker or decision maker whose decision really influencing my life as a person living with HIV. So in this case, we are talking about quite wide group of people. Yeah, Tristan, I see your hand. If it's something.
No, Anton, thank you. You just kind of reminded me of something else I just wanted to add to that HIV specific piece, which is, of course, what we're really talking about in terms of capacity is seeking funding. We need resources. to be able to deliver services. And to do that, what we need to do is particularly highlight those people who are disadvantaged or discriminated against as they age and need more complex care. And that's why, for me, it's very important to be able to highlight what is specific in the HIV space, as you've just done so very well for people who inject drugs in particular, because that gives us some weight to be able to say, you know, these are the issues that are specific in this space that need funding and resource and that are not equitable. So really, really important. Thank you very much.
Yes, thanks.
I was just going to add to that. What Tristan said is, and I'm sorry to sound fractured, in the LGBTIQA+ umbrella, a lot of, when AIDS first came around in the early, when it was the early 80s, when it started, and before probably, there were a lot of organizations that have mission statements to serve for AIDS and HIV. And by the time, I'll just say the early 2000s in some countries, it depends on what country, those funding allocations from federal governments and state governments or whatever, I'll just leave it at federal, state governments I'm familiar with. It's clear that the amount of funding, because of so many people had died, went to LGBTIQA+ general sexual health and preventative care, and as far as, and then with COVID, and then as far as with age creep. As people got older, the elder HIV communities, the programs are just languishing. They're not being really funded, and it's hard to get the money back.
Yeah, thanks, Joe. I think we should not forget that when we are talking about resources and funding issues, it's for countries like and region where I'm from, it's less about sometimes less about I mean, ideally, of course, it's government or state funding, but you know that many countries are heavily dependent on donors funding, like Global Fund. But anyway, whatever this funding source is, whether it's PEPFAR, Global Fund, or any other donors, of course, it's always question for us as a community. First of all, that to have this funding, to use this effectively, to have some kind of accountability. And of course, this is also part of the discussions when we are capacitate decision makers and, I don't know, pushing these messages regarding funding where we are as representatives of the community in the decision-making processes. So that's what, just to summarize and like to give some ideas for next discussions. For me, or for the person aging with HIV, with my picture, it's of course very relevant and very important to change public policy, to have enough attention to aging and HIV. Yeah, because many important things in HIV field started from raising awareness and changing policies, like whether it's a methadone treatment, opioid agonist therapy, or I don't know, whatever, rapid testing, Hep C treatment as a co-infection treatment. Everything started from policy changes, because legal framework, whatever, you know, Ministry of Health Acts. Also, we know that even when policy is changed, when some, I don't know, you have a law, you have Ministry of Health order, it's not always translating into the practice on the ground level or the level of certain healthcare facility. That's why, of course, change community and or community level, let's say. So that's why changing community and clinical practice to implement models of care for aging or older people living with HIV, it's also a very important need. And of course, as I'm always saying, I want to, I know that there are people, you know, much older than me and living with HIV much longer. But for instance, we know that many of the things or health issues which are really relevant for people, older people living with HIV, it can be well prevented if you know, if you're aware about that. And if you have access to proper, I don't know whether it's biomedical interventions or other type of interventions, it can be prevented. And of course, I still have some time for myself, and that's why I want to prioritize the prevention-based models of care to prevent this number of health issues. And finally, of course, is something which is already arised in our discussions. It's about funding resources, where we as a community, because nothing about us without us, right? And where we are in this process of capacitation or advocacy and among decision makers or policy makers. So that's yeah, next slide, please. Yeah, as you can see, that's actually very well correlates with the top 5 of priorities from survey, advocacy and policy change. And next slide, please. Yeah, as well as you can see that many unmet needs are best addressed upstream through government or organizational policy change, whether it's service availability, access or quality related issues, or access to resources for health. And next slide. Yeah. So on this at this point, I want to I would like to open the discussion, but we decided that we will go through all 3 priorities first, and then we open discussion with all 3 priorities. So just keep in mind to prepare your raised hands. How do you see the priorities and activities for iCOPE HIV, International Coalition of Older People Living with HIV, to help build decision maker, policy makers capacity? What is real action which is needed now to make it to make it real action? Thanks. And floor to my right.
Okay, so I think it's up to me now. I'm taking it over from Jules yesterday. Okay, Jules Levine yesterday was with us, and he did a very nice presentation, introduction, and he solicited a very good discussion on this part of, regarding quality of life. So I'll be taking over from him today because he's not was unable to be here. And as you can see in this slide, this was prepared by Jules, so where he talked a bit about his personal, let's say, situation, who he was, how long he's been living with HIV, and his priorities for quality of life. And what I can say is, okay, my name is Mario. I'm from Italy. I will be 70 years old in a couple of months. So I'm among, and I've been living with HIV for over 40 years now, just like Jules. So I'm one of those old long-term survivors. Okay, and but besides the medical part, I have my list of comorbidities as well. It's a bit different than maybe Jules's, but I have many problems as well, physical problems and other kind of problems, and other but I have this so many concerns similar to those of Jules. And for example, and I have many priorities similar to those of Jules. First one, for example, Jules was saying what he needs today is better healthcare. I fully agree with him. It's the same thing I need. I mean, I acknowledge the fact that, I am getting older. As all older people, of course, I start experiencing a series of, health problems, health conditions. But I think that many of these, of course, I have my specificities as a person living with HIV, also who has been co-infected with hepatitis B and hepatitis C. It's a long history of different health conditions. And this somehow is part of my, let's say, global picture of health. So it's not only about being older, but it's about being older with HIV. And what I can say, what I also share his priority about that, about the relationship with his doctors. So he says he's talking about wanting a good relationship with his doctor. Well, because he was talking about the fact there were time constraints in in medical visits with the physicians, his HIV doctor, and this is something I can agree on. I mean, we all know how the health systems are structured today, especially in many parts of the world, most parts of the world. in which very little time is dedicated to patients. And of course, for someone who starts having a series of additional, health problems, this can be very limiting. It can be very unsatisfactory. It can be very, even frustrating sometimes. Just, getting to your doctor, not being able to express what you want to express, not maybe getting the answers you want to get, and so on. So this is something that I think is one of the problems today for older people living with HIV. It may be different for, younger people who are in good health. I mean, but for older people living with HIV, this does represent a problem. And it's also the fact that, we are navigating, as you get older, you start navigating other health other clinical specialties. So it's not all there in the HIV clinic, but you have to start moving and navigating the healthcare system, which becomes more difficult because it's not usually all in one place. So this becomes, even if you start having, let's say, problems like frailty problems, or problems in in moving around and transportation and so on, this can be very challenging. And here we have to we also, let's say, can experience. Well, I can tell you something about my personal experience, for example, which is, let's say, a bit contradictory, because on one side, we know that there is stigma within the healthcare system. So today, after 40 years, there is still stigma in the broader society. Well, I went to this, was about 6 months ago. I had to do just a series of examinations for, let's say, to get some social benefits. So I went to many different specialists in let's say, a 2-month period. I went to about 6 or 7 different specialists. And so what I perceived was, I was, let's say, expecting, let's say, a different kind of treatment. So I was perceiving some kind of possible discrimination, or, a different, let's say, approach to me as a person living with HIV. So surprisingly, I found this was not the case. Okay, in all my these navigating the health system outside the HIV clinic, I found that actually I was very well welcomed by different specialists, and nobody actually had any problem with me, being there. So this is just to say that, many of the things that I was experiencing 40 years ago, when this was very, very common, people would not even come next to you, or sit next to you at the time. But even in the healthcare system, I mean, I had very big difficulties in getting even minor, let's say, examinations done by physicians or nurses and so on. So it was very surprising. It was a good surprise, though. It means that things are indeed changing somehow from this point of view. But then, okay, other things that, let's say, go back to what Jules was saying yesterday. Another part is about education and being up to date. This is something that for me has represents something very important from my personal story, because about 18 years ago, I am a very stubborn person, and I was not, let's say, doing what I should have done. And so I ended up in a very bad very bad situation. I was not taking my medications. So I ended up, let's say, risking my life, actually. And from that moment on, things have changed. And I realized how important education is. I realized how important it is staying up to date. And I realized it again today, in this last period after COVID, because I was not actually perceiving what was happening to me. And my doctors were not perceiving it at the same time. I must say that I have a good relationship with my doctor, which has been following me for 40 years. But he's one of, let's say, I love him. I mean, he's saved my life so many times. I can call him even on Christmas Eve, and he will respond to me. So from that point of view, he's a great, great friend and a great, great physician. But at the same time, he's one of those old-fashioned doctors. He doesn't really look at what you call, he's still, let's say, he, like many doctors, are still, let's say, tied to that, perception, we've gone through so much shit. And, now we are, you have good medications, you're still alive after 40 years. I mean, and we have your viral suppression under control, but it actually doesn't go beyond that. So he doesn't really actually go beyond that, understanding what means to me, what I need in my daily life, to have an acceptable quality of life, which takes us to that number 3 point, is about physical function. I am experiencing a series of problems regarding the frailty. I am in a pre-filled state. I have sarcopenia, but I only discovered this after I went to another clinic in Italy where I did, let's say, a checkup, which was, let's say, focused more on my overall health, on what the things were, let's say, mattering to me, what was happening to me. And there I understood that it was very important for me to be educated on these things, understand well my lab tests, understand what I could do myself besides what my physician could, propose to me. So this is something which was very important for me. And number 4 takes us to mental health. Okay, we have all been experiencing, both people with HIV, people without HIV, post-COVID. I think we've all have been, let's say, destabilized somehow, by the isolation caused by COVID has meant for each of us. But I think people living with HIV, me myself, we are, let's say, I would say we are emotionally fragile due to our condition. But maybe this comes back from the old days. I don't know if it's only that, but I still think that even people today, which are newly diagnosed, have an additional burden of, let's say, emotional problems. So I think this is something that for people living with HIV, COVID has been particularly challenging. It has been for me, for example. And so I think mental health is something that must be addressed, something which must be integrated into HIV care, absolutely. I remember in the 80s, for example, there was some kind of services, at least here in Italy, but I know that also in other parts of Europe as well, many mental health services were integrated into HIV care. Either they being, let's say, psychologists, or even, let's say, professional nurses, or social workers, or I don't know what they would be defined in English, but well, somebody who would support you. At the time, it was some type of a kind of support for people who just, let's say, end of life support, mostly. People were, very close to what let's say approaching death could mean, or so that was very particular important at the time. But then after, in the 90s, when we had antiretroviral treatments in Italy, at least, let's say, this came less. And so today you don't find any kind of these services in HIV clinics any longer. I know this is happening in some parts of the UK, for example. This is happening in some parts, maybe in the US or in Canada, but not in many parts of the world, actually.
And Australia.
Australia, maybe, yeah, as well.
Oh, absolutely.
Yeah.
Mario, can I say something just because I'm mindful of time? And thank you so much. And yours and Jules' experience particularly are so important. I think particularly with the length of living with HIV, it's the really, a key thing for us to be able to tease out. But my slight issue is that what we have on the screen here is something that all 73-year-olds want. And I think we have to be very careful about exceptionalism in a very crowded space. And what we will get in terms of pushback, for instance, in the UK, when we're seeking for funding, is many people will say, well, look, your cohort have already got direct access to a tertiary specialist. You have in-house psychology. I appreciate we're quite lucky. We work in a big centre, but it makes it even more important, I think, to try and tease out some of the specific HIV-related stuff, because everyone's going to say COVID was tough. Everyone's going to say, I want better healthcare. I want better integration. I'm really struggling as they age. I'm not saying it's not true. I'm just saying I think there's something very important in the work that we do together as a group to think about different groups in different country settings to try and make that case for what really is, what we can prove to be different about the HIV situation and what therefore specifically needs better funding, which isn't to downplay anything that you've said at all, which is tremendously important. I'm just a little bit time pressured and just kind of explaining some of the difficulties we get when we try and make a case for bringing some of that back in-house, doing it in a more integrated way. We kind of get told, you know, what's specific about this population that we really need to put funding behind, and what are you telling us that's just kind of a general feeling. I mean, I guess that's the pressure we have, and that's the challenge we have when we try and get better funding to do this better.
No, I think I fully agree. I mean, this is okay. I'm bringing a personal case just to try to, let's say, bring a more general thing, which we see on that previous slide. You just put Kate, you know, with, trying to trickle out what are the specificities of each, because as you say, Tristan, you know, you probably know better than me because you've been working on this for so long. Specificities of people aging with HIV. So we have to really advocate when you go back and go to funders. We have to show them, we have to make our case, I mean, for things, you know, for what we want, what we need, and so on, which are our specific needs. Okay.
If I can, rather than write it, because it's easier to say, and I'm pretty blind. I hear what Tristan's saying. I agree. And what we need to do is, and the way I'm advocating to here in Australia is, I use numbers. I take the total number of, there's 30,000 people with HIV. There is half of them are elder, and then there's people that need the extra care because they are elder, and they've had the older drugs or no drugs, and their bodies have had 40 years. And the younger people that are getting the newer drugs that aren't getting the side effects and the glossy things, there's a really big discrepancy. So right there, I can take 30,000 and split it in half, and then even another number that's very specific to people that need help right away. And I think that's what each of our countries or areas, regions need to do. We got to be very specific with numbers.
Yeah, data will be very important. Collecting and doing research in this sense, I think, will be very important. Because if you make your case, you have to make your case with numbers, of course. True. So can you go back to that slide, Kate? Jules' slide, the one. Okay. So I think that's about it from this point of view. Can you do the next slide? Okay, here in this slide, okay, Jules was pointing out that, you know, just the same things that we were saying before, that besides many of the things that, okay, the question here is the same. What activities could iCOPe do to help maintain and improve quality of life among aging and older people living with HIV globally?
Okay, so Axel, we'll go to you, and then we'll come back to more discussion after that.
Hello, yes, I'm Axel from Brussels. Thus, I would develop, let's say, the third priority, increasing knowledge. I should say not only knowledge, but we have to go to education, which is more than knowledge. It's going to getting the knowledge, but also to action. And in fact, we hear through the survey already that there are quite a lot of unmet needs. For example, in the care environment, we hear about the big wording was comorbidities and a lack of prevention, screening, coping and management. So that's somewhat the environment. Next slide, please. Because I will, let's say, as an illustration, somewhat put me here in front, but that could be maybe any other 60+ person living with HIV. I'm living for more than 30 years with HIV. having numerous comorbidities, cardiovascular problems, macular degeneration, there's the eye problem, neurological problems like neuropathy, including also the neuropathic pain. And I must say, even that if I have a medical background and quite proactive in searching solutions, most of those comorbidities, and I'm living in a rich country, Belgium, were detected by coincidence and were already in a late stage. Thus I missed all preventive actions or assessments. I think it was Anton mentioning his aim to be further in a treatment related to a prevention-based model of care. Obviously, I agree. I missed a lot because there was a lack of prevention actions. But that's a general aspect about medicine, a lack of prevention. Thus, I arranged my specialist visits myself, being quite proactive, but there was no coordination or guidance by the HIV center. Even that I have very good relations with the physicians, but there was no case management because it was not linked in an appropriate model of care. Focusing on my education priorities, there would be first understand why I'm getting to those comorbidities. What are the mechanisms behind? And it's only now the last 3 years that I start to understand, and also that I know how to prevent, but it's quite late now because it was detected very late. Thus my aim would be still now to further better prevent by improving my lifestyle, getting the better treatments, and be empowered to get the best treatments. Because in this bunch of all different specialities, Tristan was speaking about what is specific, but what I think is specific in HIV, that it's a complex disease. We hear about a lot of different physical aspects, getting in touch with different specialists, but also all the kind of psychosocial and mental aspects. Because that's quite specific to HIV. It's not one pathology, it's a multi-pathology environment. But then coming back to the reality of today in Belgium is that, for example, related to my neurological or neuropathic problems, my HIV specialist, which is a well-known specialist, and a neurologist, for example, they say only recently, but I'm suffering from my pain already some years, that it was due to neurotoxic HIV medication. But they didn't mention, for example, that it could be also linked to the HIV itself. HIV itself can develop neurological issues. I will not go in detail, but that is, well, plenty studies about this. Thus, the problem is that they don't say it. Thus, I couldn't plan it in front. And we spoke about frailty, pre-frailty. Obviously, neurological problems are linked to be well known and educated in a pre-frail situation than in a frail situation, because it's much difficult to get to reverse it, even if it's not possible to reverse. Just my aim for priorities is to be in a better, just was saying by Mario also, in a better healthcare environment where prevention is a focus. And since HIV is a complex disease, prevention should be even more important. But prevention, that means that I should be empowered, educated, up to date, but as well, the healthcare professionals should be educated. Even those in HIV, I got feedbacks from physicians saying, because I was organizing recently with physicians a symposium on HIV and aging, and some physicians said, well, we are not so well educated in HIV and aging, and they are seeing 50% of their population being older than 50. That's a contradiction. Thus, better healthcare would be for me also to be in an environment where geriatric assessment and care is a model. So also that frailty, not only physical, but also mental, is done right in advance in a pre-fail situation. And this cannot be done in a 20-minute visit. Thus that should change. And obviously better healthcare for me would be having different comorbidities, have a care coordination, case management. Thus overall, just like said before, I would like to be better educated, up to date, so that I can prevent with self-management, with going to the right healthcare professionals, prevent a loss of quality of life due to my comorbidities. And for example, only one other example, in Belgium, a rich country, I say it again, where I don't get my lab results. Thus it's difficult to see evolutions and so on. Mm-hmm. Thus overall, just what said before, that was the wording of Jules yesterday, even that I start to know that I can manage better and better myself because I educated myself a lot, but I'm still worried about the future, my future, become more incapacitated and questioning myself, who will take care of me? So that's somewhat the description. And next slide, please. And obviously, what has said be in the survey, there are some priorities which are physically, social, psychosocial, mental, and also policy. That's the purpose of obviously of the iCOPE strategy towards actions is to tackle those priorities. And from an education point of view, for example, the question was, what are activities can be done? And for example, yesterday, the focus was on education activities towards self-management to empower the patient and the community. We cannot expect everything from the healthcare professionals. We need to educate ourselves, and the community should be educated as well. Thus the focus should be on patients to help them further take actions. Thus I would appreciate that you would, through chat or through saying, give us some concrete ideas how within what we hear at the webinars or other ways, reporting or informal social media, what we could do to focus on education, addressing those priorities, mental well-being, social isolation, obviously all what's done related, what's about comorbidities, cognition and advocacy. Thus, I think it's time now for discussions.
So just to facilitate this process a little bit, we've talked you through some of the priorities we see and a lot of the problems, but what are the solutions? So we want to really translate this into activities that will make change. So we're interested in your ideas. Tristan, you're back.
Thank you. Yeah, I've just been told that I can kindly be given a lift into work, so that gives me an extra half an hour. So thank you all very much. I think the thing that was coming to my mind is, I totally, the way I have a way of thinking about people at different times of diagnosis in terms of HIV, and I agree that those who are diagnosed before 96 or got older drugs are very likely to age very differently. I guess the theme that was coming out for me about some general work that we might be able to do and some applicability in different settings and different populations is really thinking about what the right screening tools are that people should be using, thinking about the right questions people should be asking to identify those who have complex needs at any age. Actually, 50 doesn't need to be a cutoff. We've heard from Anton that obviously people who have been diagnosed with HIV at a very young age or have been injecting drugs for a long time may become frail and develop complex needs at a younger age. So I think some work on simple screening tools. I can see Lucette's got her hand up. This reminds me of thinking about neurocognitive impairment. Very, very difficult, of course, to find a good screening tool. But I think in this field, we need to think about something people can be offering to everyone in many different settings as they age. And of course, if you use a screening tool, what do you need to do? You need to then have somewhere you can refer people onto for complex care if you identify them to be complex. But then again, it's about something, and we've heard it certainly from Jules, not everything fits into a 20-minute appointment. So one of the basic things I will talk to people about who don't have a lot of resource to provide these services is just identify your people that are, I don't like this word, but stable, don't have complex needs, and offer them a standard appointment. Identify the people who are more complex and offer them a longer appointment where you can really address some of the complex needs. And then that's cost neutral, right? Because you're not putting anything extra in. So I think some of the work we could do is around what screening tools could people expect, and then what basic standards could people with higher complexity with HIV expect in many different and perhaps some lower resource settings in addition to those that have better resources. And I think that could have, as I say, applicability in different country settings and in different individual groups as well that may be differentially affected by HIV as they age.
Can I ask you a question, Tristan? Do you think that patient-reported outcomes could be a good tool to use? I mean, both by the physician and also by the patient himself, or herself, to, let's say, identify some of these, needs or concerns, because sometimes they are unexpressed during consultations. Let's say very quickly and bluntly, they're not well understood by the clinician, and they're not very well expressed by the patients. So, I mean, I have found them personally useful, but I just wanted your opinion in your clinical practice, if you think that they can be something important to think about,
Thanks. I'll just try and keep this brief because I can see other people have their hands up, but I guess there's a few things that you could bring in here. One is proms, indeed. Some people actually have said to us when we've piloted them in our clinic that they find them quite triggering, and actually they just don't want to answer them, which is interesting feedback. One of my colleagues is using a combination of measures of medical complexity with patient activation measures to gauge level of education, level of engagement with healthcare and so on, to try and stratify people into those who are kind of perhaps lowest in terms of health education and able to navigate systems that are complex, with the greatest need as being those who need the most investment. And then I think you have to think, so there's proms, there's patient activation measures, there's measures of medical complexity, and then I guess the other thing to think about is objective measures. So objective measures of physical frailty, or grip strength tests, time get up and go tests, all of those things that may give us some extra information, and maybe simple screening tools to look for physical frailty and sarcopenia. So it's going to come out of all of those different angles, I guess. And I'll be quiet now.
Madeleine, who had it?
I think Lucette had her hand up before me. Please go ahead.
Hello, everybody. Yeah, if I could say a few things. So I'm sorry, I was sort of dealing with several other things, so I did not listen to everything that was said early on, but I just wanted to say 2 or 3 things. The first thing is, I was informed of this webinar through my connection with Jules Levin from NATAP, and also from this group, and all the work he's doing with for the Glasgow Manifesto. And we actually have a group of experts in neuro HIV and aging, and also linked to people from the HIV community and people with lived experience. And we've been working for about 2 years now, and we have a paper in plan. And we also have, I think, the most important for you, the most relevant, we also have a satellite plan for IAS in Brisbane. And so one to respond to the current question, one of the item agenda for our satellite symposium is going to be solutions and what kind of intervention we can do. So what we've done, we've concentrating on the solution that exists for the non-HIV population in terms of preventing dementia, preventing cognitive decline, and also preventing, you know, all the associated mental health changes. So we're concentrating on that, and we have going to have someone who's been working on this in HIV in the US, who's been adapting some of the program to people living with HIV. So we believe that the program for intervention to at least, if not prevent cognitive decline, at least slow down the trajectory of decline in some people, not everybody, of course, but already exists, and that they have not been delivered in the same extent that they could be in people with HIV. So that's what we want to try to kind of to fill that gap. And I've heard earlier someone mentioning the geriatric framework, and I think that's kind of the framework we want to use as well. And the other thing is that we also will cover models of care, because I think it's the discussion that needs to include model of care. Sorry, and also there are some national differences in terms of model of care. And the last thing I will say is that I don't think we should only think that all the people who have had, you know, not the best treatment early on are the people who are the most worse off. I mean, they have, obviously they have some legacy effect, but I think it's more complex than that. A lot of people with HIV overall have a higher level of comorbidities. And I think if you look at the last result from the HIV and aging study in the US from the Charter, when you look at their young group, the young group is actually not healthy at all and has all sorts of issues, which are also risk factor for cognitive decline when they will get older, that generation as well. So I don't think it's something that is about to get completely better, even with the next generation. Anyway, so that's what I wanted to say. So in terms of solution, if you are interested to be part of our group, you should definitely contact me or contact Jules. Thank you.
Thanks, Lizette. We appreciate it.
If I could.
Oh, wait, sorry, we're going to go in order of speakers, John. Do you just have a comment?
Sorry, is there?
Yeah.
I can't see.
Oh, yes, sorry. We have Madeleine and then Jay. And
can
then
you put me in order? I can't see very well.
I absolutely can. And then I think you'll be the last before we kind of end by just sharing the opportunity to join the steering committee. So Madeleine, you're up.
Thank you.
Okay, thank you so much. And thank you for the opportunity to join this group. My name is Madeleine. I'm based in Canada, in Montreal. I would like to speak to two things that I think are very actionable. And one is the need to lobby funders to put HIV on the agenda as a non-communicable disease, which is what it is under U=U. I don't know what's happening in other countries, but in Canada this year, the HIV Network on Research has been told you're not doing HIV, you're doing HIV and STBBI. And the Public Health Agency of Canada, when they wrote their strategic plan, have removed HIV from the title. This used to be the HIV strategic plan, then it became HIV and STBBI, and now it is STBBIs. This is very dangerous in terms of research funding. And I like your comments about finding funding, Tristan, because this is le nerf de la guerre. We need funding for this. And funding for non-communicable disease is not the same extent of funding as for communicable diseases, right? If you're going to wait around in trials for cardiovascular diseases to happen, you need massive fundings. And this is, so we need to lobby to keep HIV on the agenda. I'm not saying don't do transmissible HIV work, it's also important, but I'm saying in the context of aging, this is a chronic, non-infectious, non-contagious disease. And this is going to feed into my second point about trials, because we need interventional research on HIV and aging. And one of the major hurdles of interventional research on HIV and aging is outcomes. And I like the ideas of PROMs coming up, because we need PROMs that can be used as outcome for clinical trials. So HIV clinical trials used to be easy because you measured viral loads at the end, and that's what's telling you, and you could even do CD4s, and that's what's telling you whether the drugs were good or not. But aging is so much more complicated to capture. So the general medical approach has been to silo aging. We're going to look at cardiovascular disease. We're going to look at neurocognitive. We're going to look. I think we all feel that HIV and aging is a much more global and sort of systems-wide process. And how do you actually, I'm designing a clinical trial now for HIV and aging, looking at exactly what you wrote in the chat, Jay. And I'm thinking, what are the best outcomes? And I think this is an opportunity for people with lived experience and people living with HIV to co-define the outcomes that we're going to push forward in the interventional trials agenda internationally. So I think this is an actionable point that we can do. Participate to co-define the outcomes for the trials of aging with HIV. Thank you.
Thanks so much, Madeleine. Very actionable and both very important. Jay, over to you. Oh, we cannot hear you. You don't appear to be on mute.
Apologies, how's that?
There, better.
Cool, new headphones, new office, new job. Great to be here. Yeah, I agree with everyone. This is a big issue, and some of our most vulnerable and needy are possibly potentially going to be more vulnerable and needy going forward. So, you know, this is a big priority in terms of our work here. I wanted to ask Lucette, is there any evidence or any research going on looking at potentially boosting treatment combinations so that they are more neuroprotective?
Thank you.
And if so, what should I take?
Yeah, no, thank you. I mean, I was starting to reply to you by text. The truth is that at the moment, most of the current antiretroviral treatment do now cross the blood-brain barrier, the newest one. There are some of them that, I mean, old version of treatment that maybe people should avoid now. I think the best way to assess that is would be to go to see a neurologist and assess your treatment. But basically, if your viral is undetectable and you're doing well on your treatment, there is no reason to change it. That's the best treatment for the brain anyway. However, in some instances, people have what we call cerebral spinal fluid escape. So the virus start to replicate in the cerebral spinal fluid and not the rest of the body. So if people would start to develop quite, obvious cognitive impairment and other difficulties, so in that case, you would want to act and get on a different treatment. So we're not at a period where we are. There's been a new treatment, or even outside antiretroviral that's directly target anything in the brain yet. We don't have that. It's just not there. So what we have, however, is a suite of intervention to help prevent, a steep cognitive decline. It's not what we see in HIV anyway, but we kind of need to try to prevent 10 years ahead of time. The main thing I would say for a lot of people with chronic HIV is maintaining your cardiovascular health as best as possible. So a lot of things are like that. They're not actually directly HIV, they're all the other comorbidities, and cardiovascular health would be the main one. So for example, if you've got raised cholesterol or high blood pressure, try to deal with that preventatively. Yeah.
Great.
That's
Thank
where
you.
that's where we are at the moment. Yeah. And then the thing what we're trying to advocate through our group is to make sure that eventually people with HIV have access to treatment that are being developed at the moment for other form of dementias, because at the moment people with HIV are excluded for all the dementia trials at the moment. So that's something that people don't know often, but that's a massive issue in a way. So,
Thank you both.
yeah.
So I'm going to invite John to give a really quick last comment, and then we need to wrap up.
I'm going to try to do this. There's a few things. One thing is I want to go into the global big picture of where I learned about you and all that. There's the Glasgow Manifesto, the 10 calls. And I think if we organize these things underneath that, and also you had 170 some signatories, and I can tell you, it's not trying to sound sexist. It's like putting lipstick on. Just put it on, sign, and don't do anything. And I can tell you that I can know multiple organizations that have signed and they don't deliver to the community, or they just deliver right in their neighborhood. And so I think that those people that have signed, they have mission statements. I think it would be good to check their mission statement. This is also from a national perspective. Check their national mission statements. Are they delivering? And delivering to the Glasgow Manifesto, and everything falls underneath it. I can tell you that Australia won. In Canada, Europe, US have a lot of clinical studies, not only just with HIV, but HIV elders and getting older, neuropathy, etc. There's no research trials whatsoever for elder HIV. It's basically taking a pill and be happy. I'll leave it at that. I could add more, but that's kind of it. I think if we can go back to your 170 some, they've all got mission statements. And are they really delivering the Glasgow Manifesto under the 10?
That's, that's a really good point. That's getting
big
people to act at home before we go broader than that. Yeah, for sure.
Yeah, because they've signed and they're not delivering.
Yeah. Okay, Mario, you get the last 2 minutes before we sign off.
Yeah, okay, I'll be very quick. Okay, well, thank you all today for your participation. We've had a very good discussion, just like yesterday as well. Well, the results show that today, the survey results presented here today, they're the result of the many voices from all of those who share our same values and concerns, that we can have been summed up in those three key pillars of improved care, optimal quality of life, and empowerment for older people living with HIV. At the moment, we, as a group, we are reaching out to potential funders who share our same vision and objectives. And we're trying, but at the same time, we acknowledge that we need to start creating a structure that can better reflect our global outreach and respond to criteria of inclusivity and diversity. So today we will be launching a call for steering committee members. Can you put on next slide, Kate? Okay, so we're aiming at having a steering group composed of 10 to 12 people, ensuring representation from all global regions, and ensuring diversity and respect with respect to gender identity, race, ethnicity, and sexual orientation. And of course, our applications from aging and older people living with HIV are strongly encouraged. Next slide. Well, the role of the steering committee will be that of providing guidance to iCOPe HIV's executive committee about strategy, priorities, work plan, and identification of funding opportunities. And the committee members will have a 2-year term with meetings, be monthly meetings, so every 2 months. And the work will be on a voluntary basis. So next slide. So it's a brief online application form that will be open from May to end of June. You can find more detailed information in the application form and on the attached steering committee terms of reference. You can also access the application form directly from the link you see on the slide here, or that Kate will be putting here in the chat box as well.
Already done. Yep.
Okay. Well, in any case, we will be disseminating the call further in the coming days. So we encourage those interested to apply and further disseminate within their networks. So just to end, our time has run out, of course, and we are at the end of our webinar, which I hope you have all enjoyed. And just before leaving, I want to ask you if you could please fill in the two questions, these poll questions. The first one has just come up. That will maybe give us some guidance on our next steps and activities. And finally, I want to thank you all for your contributions today and expressing your different and valuable perspectives.
And I want to thank you for the time difference and going to the southerly part of the globe. Thank you.
You're welcome. We really wanted to make sure that the folks who didn't get to participate in the original webinar would get to do so now.
Yesterday
I
was
think I did it at 1. It was 1 o'clock in the morning or 3 o'clock in the morning or something like that.
Yeah.
Which it is for you now, isn't it?
It is what? Yes, it's 2:30 in the morning for me right now.
Yeah. So thank you.
You're most welcome.
Some rest, Kate. Thank you very much indeed, everyone.
Thanks, everyone.
Thank you. Everybody.
Have a
Thanks,
great
everyone.
day.
All right.
Thank you.
For me, it's good night.
Good night.
Good night. Good night.
Bye-bye.
Bye.
Keep
Bye-bye.
well.
Thank you very much.
Mhm.